Today, this morning, I've requested 3 of them to share their work. And I'll begin with Associate Professor Elona Toska of UCT's Center for Social Science Research. Elona is a Chief Research Officer at UCT's Center for Social Science Research. She's a social scientist working at the intersection of public health, psychology, social work and development with a focus on the second decade of life, also known as adolescence. Her research focuses on identifying ways to support adolescents and young people, including those living with HIV and those who are adolescent parents. The aim is to help them to have safe and healthy relationships with the people in their lives, partners, caregivers, teachers, and healthcare providers. She works closely with government partners and UN agencies in several countries in the region, including Eswatini, Kenya, Lesotho, Mozambique, South Africa, Zambia, and Zimbabwe. And I want to invite Elona to come and share her work with us. Over to you, Elona.
Good morning, everyone. Can you hear me? I'm going to use my favorite phrase, maybe you will all allow me, all protocols observed. I've already put my foot into a conversation this morning, so I just want to say it's a great honor to be here, and it's wonderful to have seen and heard from countries and where we have colleagues or students from, or receive funding from, or have research collaborators in. I wanted to talk to you about adolescence, but one of the things about all of us sitting here who may be looking after adolescents, looked after adolescents, is annoyed by adolescents or inspired by them, is that we've all forgotten what it is like to be an adolescent. So maybe put your hand up if you were a really A-type adolescent. So you followed all the rules and you did nothing wrong in your life. Okay, it's not everybody here, so remember that. Remember that. Put your hand up if you were a really confused adolescent. Okay, I was also very confused, but I hid it very well. Put your hand up if you knew at the age of 12 that you were going to be an attaché, head of mission, ambassador, anything? Nobody. 1, okay, okay. Kudos, I want to know. I want to study you next. Okay, great. So I want us to remember this, because maybe you're sitting here thinking, I came here for the mining in Daba, or I'm here because I'm interested in students, or I'm here because I'm interested in education, or I'm interested in what's happening to the library at UCT. But all of us, our lives is investing in the future. So I want to tell you a little bit about how we've been trying to do this as social scientists. So there's not going to be anything about vaccines and medication directly here, but there will be some about how they interact and overlap in our lives. So I'm not doing this work alone. I know as an emerging career researcher, you're sometimes meant to say you're like amazing and you made it all by yourselves. But actually, I work together with an incredible number of colleagues from all different walks of life and all ages. These are just some of them. And I didn't actually count the countries, but I think that's about 20 of them. And I'm actually, I should have started the official representative of Albania in South Africa, because there's no one else here. I'm Albanian by birth and South African by choice. But what brings us together, more seriously, is that I used to think of myself as an accidental academic. I did my undergraduate degree, got interested in a topic, ended up in a country, and I'm doing this research. But actually, we're all activists, academics in our team. We really want to come together and try to understand, using data of different kinds, using different methodologies, how can we support adolescents and young people better, and through them, their families and the communities that many of you interact directly with. I did a map, and I've already remembered one country I forgot, so I hope these slides will not go to everyone who will spot them, but we are actually extremely lucky to benefit and interact with colleagues in many countries and regions of the world. The team at UCT specifically receives funding from multiple spaces. I already have seen colleagues from the US receive National Institutes of Health funding, Grand Challenges Canada, European Union. So thank you to all of you who make those schemes happen and who enable us to access them. But we also have collaborators in countries in the region who are really keen to use data and research. So if you work in a country in the region where you think this data may be useful and interesting, please do reach out via the research office. Why is this important? Why is this topic? You may be sitting here thinking this is really not my cup of tea or coffee. Well, by 2030, there will actually be 500 million adolescents in the continent alone, and another actually 500 million in Asia. So it's really a massive amount of population. So even if all bad things remain the same, this is simple maths with me, the number of people that will need our help and support is going to be in absolute terms higher. So this is what I sit with. Okay, HIV, 10% in incidence in Lesotho. Doesn't seem that bad, but 10% of 220,000 young women is different from 10% of 300,000 young women. And this is also will have impacts on other generations. So what's powerful in our work is that we're trying to understand not the well-being of everybody, but we're trying to figure out who are those who need the most help. And particularly thinking about young people who are most affected by COVID-19. There's an estimated 10 million orphans due to COVID-19 globally. I think South Africa alone has 285,000 just in the last few years. 1 in 3 young women will have a child before the age of 20 in the region. And we're looking at 1/3 to 1 in 2 of them not returning to school when they have to drop out of school because they're becoming parents. Many of us had to drop lots of things when we became parents, so it's not blaming, but helping them return to school is something we are not doing so well at. This is one of the, to show you that we do fancy statistics as well, not just powerful stories. We're trying to understand what's happening in the lives of adolescents living with HIV in South Africa. We'd be traveling to schools in the Eastern Cape where this data from 1,000 adolescents living with HIV is from, and we'd hear a lot about slow learners. I don't know if anyone has ever heard this. It's an informal way that teachers and parents and family use to label young people who are not progressing as they should in school. And what we noticed in these conversations, because we had about 500 who were not living with HIV, is that almost all the slow learners were living with HIV, whether they got it at birth or acquired it sexually in adolescence. So what we tried to understand was how are these things linking to doing badly at school? And what we see here is that, maybe this is where social science is a bit elaborate and confusing, is that the 3 boxes in dark blue in the middle were really it's kind of a Bermuda Triangle where these young people were getting lost. They weren't just doing badly physically. They weren't just sick because they had HIV and had TB. They also had worse mental health, and they also had worse cognitive development. And if neither of these 3 were addressed, you can see kind of it fans out as a cascade to missing out at school more and doing badly and repeating grades. So this is just some data from the 3 cohort studies in South Africa that I'll tell you a bit more about. These 3 cohorts involved about 10,000 adolescents and young people and their families in KZN, Mpumalanga, Eastern Cape, and the Western Cape over the last decade. So a lot of our analysis tries to both use the cohorts together and individually. The first cohort focused on families that were affected by HIV. At the time, things were really bad in South Africa, so we tried to understand orphans and vulnerable children. Some of you may support programming on this or work on this topic. And then we focused on adolescents living with HIV, and most recently, Hey Baby, which stands for Help Empower Youth Brought Up in Adversity with Their Babies and Young Children. I did not come up with that acronym, but it is memorable, and it's focusing on 1,000+ adolescent mothers and their children. What we've realized over time, and one cannot design a survey complex enough to capture this, which is why we needed multiple studies. To the left, and I won't quiz you on this, you don't have to read the slide, it's just a marker. You'll see that young people do not actually wake up in the morning. I mean, none of us do. I don't know how many of you are on chronic medication, but I doubt you wake up in the morning and say, today I am my diabetes, or today I am my hypertension. And this is true for young people. They don't wake up and say, today I'm going to protect myself from HIV using a condom every time I have sex for the entire time, which is kind of what we're telling them to do. So we're trying to understand these overlapping risks to the left. There's climate change, there is conflict, there is epidemics, and they go through fairly shared pathways. This is what our data has documented over time. And they all impact similarly negative outcomes to the right in the lightest and brightest blue, which are things that many of you, I hope, are interested in and are trying to stop and prevent. So I've given you a bit of a doom and gloom start, perhaps. So for the rest of this, I'll give you some data on what we see maybe making a difference. There will be a few of these spider-looking diagrams in the next few slides. In the middle, it's always something we know young people are receiving. So in this case, it's three things: going to a safe school, not being beaten by a teacher enough to leave marks, and feeling safe enough to go to school. The child support grant in South Africa, which we're very lucky to have, which is a conditional cash transfer received by families. The condition is that you have to be, it's economic and age. You have to be under 18. And the last is parenting support. And this is not having a parent who spends 25 hours sorting out 3,000 pieces of Lego with you. It's not a very high standard. It's having someone, a caregiver, a parent, who knows where you are, knows who your friends are at all times, tells you when they're going away and doesn't leave you alone. So it's what we call parental supervision. It's scaffolding for young people. And believe it or not, you may know this from your lives, it's not super easy to do when you have a busy life and a stressful life, or you're the only caregiver. But those young people in our cohort of 1,500 adolescents who received all three of these, they had improvements not just in one area. The colors here are the SDGs, the Sustainable Development Goals. So they had improvements in health, the two green markers. They had improvements in education. At the bottom right, they had improvements in reduced risk, sexual risk for HIV and pregnancy, and reductions in violence in the blue. But then we want to also make sure that we keep these young people alive. Those of you who support healthcare systems, maybe you build clinics, maybe you train staff, maybe you train future health researchers like me and like myself and some of our team. You may wonder, but we can't do everything that is needed. We'll never have the perfect medical setup. Well, not never, but not anytime soon. So we'll need to prioritize. So what we did in this analysis is we tested, statistically, 11 different features of a healthcare experience of a young person. Did they think that the nurses had all the answers? Did they think that their information would be kept confidential? How long did they wait? How long did it take for them to get to the facility? Two things were critical to 5 health-related outcomes. If they were on antiretroviral medication, being suppressed, so having the virus under control, not having TB symptoms, not having interrupted healthcare, so going to the facility regularly, and not missing their treatment for 1 month or more. Those are all really good things that we want. Adolescents are dying in this continent because of 3 things: AIDS-related complications, road related injuries, and violence. So we really want to understand how to address these outcomes. And the 2 things in the middle, maybe you'll be blown away, maybe you'll say, but we needed the data for it, was that they felt treated kindly at the facility. They did not feel shouted at, and they could get to the facility safely and at no cost. But it's not only about what we can do in the healthcare system. Amongst adolescent mothers, a lot of people are trying to think, what do we do with them? There's a large cohort. In South Africa, there was a 46% increase of adolescent mothers 10 to 14-year-old during the COVID-19 pandemic. This is based on hospital birth records, and we have very good records. In Eswatini, there was 1 year without contraception stock in the country during COVID-19. What will that have done to adolescent pregnancy? So we've been asking ourselves, we make these young women invisible. They are blamed for having unprotected sex, though we know it takes at least 2 people to become pregnant. And we've been trying to think, okay, let's move away from the stigma and be proactive. We tested a few different factors, and one of the strongest is having enough food to eat at home. And here you'll see that those young women who had enough food to eat, young mothers, in the last week, had reductions in transactional sex from 16% to 3%. Now, 16% may not seem like a big deal, but that's where HIV acquisition and that next pregnancy takes place. And they're often in the context of violent, unsafe relationships. Then you'll see the reductions in not being a NEET, those of you who work in education and employment, so not in school education or training, and improvements in reductions in substance use and sex while on substances. The other factor that was critical, and I won't go through this for a very long time, was childcare. I don't know if this is a no-brainer to you, but no one thinks about giving childcare to adolescent mothers. We just expect them to get on with it, deal with the issues that have happened in their lives. Well, when we tested, this is the same cohort of 1,000+ young mothers and 1,200 of their children, already some of them have multiple children, those who had access to childcare saw improvements not only in their own education, they could go back to school, they were better parents. You'll see in the 2 circles in blue. They were better at setting limits, play with their children, and their children had better outcomes. And we're lucky in South Africa that there's great interest from the National Department of Basic Education on this. I'll tell you about that in a moment. But how do we take this data to other countries has been one of the questions that I've been sitting with. It's costly to run these studies. So we're working with colleagues at the DBE in South Africa to think about collaborations with Eswatini or Lesotho, which are countries nearby where they have existing, or Zimbabwe, where they have existing relationships, to think how do we actually take some of this data and use it in places where there isn't a large study to document this. And most importantly, we're doing all of this talking to young people themselves. That's why I started at the beginning saying that I always feel like a 17-year-old, but I'm currently a 17-year-old with a couple of decades of experience and a couple of decades of forgetting what it is to be a young person. And that really makes a difference how we design and treat design programs and services and how we treat our young people. So we do spend a lot of time doing that and bringing them together with colleagues in government. These are our 3 colleagues from the National Department of Basic Education. And what we've been doing specifically in South Africa, and this is an area I'm very uncomfortable with as an academic, because I can't tell you how many high-impact journals I'm going to publish this in, which is some of the metrics that we use. But what I know is that where we need to be as a team. It's easy to say, do childcare, give food, help them return to school. But how do you do it? This is an area we now call implementation science. Many of us do it in different ways, but it is a type of research, and it is very powerful. So our colleagues, supported by the Strategic Fund at UCT, are going to actually try this in a couple of schools in the Eastern Cape. So working with the National Department of Basic Education, school boards, young mothers themselves, the fathers of the children, if we are able to connect with them in a safe, non-stigmatizing way, to try and think, what is the package that supports young women and their children to have the best possible long-term outcomes? Our quantitative data analysis, to summarize, highlights 4 things that support them return to school, support them complete their grades at an age-appropriate stage, and reduce future pregnancies and HIV risk. And I'm sorry, the font color is a bit dim there, but the top 2 are staying in school as long as possible during pregnancy. And I know that makes people really uncomfortable because there's a lot of myths around that, which I'm happy to chat about at the end of breakfast. It is supporting them access childcare when they're ready and when the child is ready. It is building their confidence and thinking and dreaming about the future. And it is providing and linking them to youth-friendly services, the not feeling shouted at or judged. So we've designed some components with young people. We had what we call design incubators with colleagues from the National Department of Basic Education, and the launch workshop in the Eastern Cape is on Thursday next week. So I'm very excited to see what our team and colleagues and government and schools do, and young mothers. We've taken some of this implementation science forward in other places. One of the things that we find, this may also not be surprising to you, is that exposure to violence, even when it's unintentional, being beaten at home because a parent may be too stressed out, or intimate partner violence, is one of the strongest predictors of not doing well. Right? But it's really hard to know how to respond to this. I know many of you are really passionate and focused on this work. But in Zambia, what we're trying to do is take forward an element that has taken quite a bit of traction recently. It's called precision prevention, precision programming. Has anyone heard of this? The idea is that as long as I know if Han, sorry if I may say, you're here, or Kheti, what their risk profile is, I'll give them the perfect combination of things that they need. But it's quite difficult, because if you're a 13-year-old who's dropped out of school because you're a herd boy in the mountains of Lesotho, or if you are an 18-year-old, very empowered woman who just wants the type of contraception that she knows she wants, not what she's being given by the nurse at the facility, this is very hard to do. So often what we rely on is screening tools. And it's easier said than done. So in Zambia, we're working with survivors of GBV activists, the male partners of these young women. They're often married before the age of 20, definitely before the age of 24, clinic teams in facilities and peer supporters to try and design what is a contextually appropriate and successful screening and support package for women who are experiencing violence and living with HIV. We started quite low, because when already living with HIV is, quite small and narrow, is a big deal. So we're trying to figure out how do we actually try and find them and support them, rather than just assume that they're doing badly because they're exposed to violence. Also stay tuned for this. Findings are coming out. And the last bit that I want to share with you about is one of the things that has been the hardest for me for my work. It has been trying to build a team of quantitative social scientists at UCT. I grew up liking math, so I also wanted to be the first astronaut from Albania without realizing there was no space program. So I had a lot of crazy aspirations, and I thought that just because I was good at maths, I'd be really good at quantitative analysis. But it's not true. I see some people agreeing with me. There's also an art to giving body to statistics, and I'll show you a few more slides here, but just clicking and doing really beautiful code on R, Python, Stata, SPSS, MATLAB, any of the packages you may have used or support people to use, doesn't actually necessarily tell you what is happening in the lives of young people. So we're using data from all these different countries that are highlighted in the map, and there's a large team that is doing it from the continent and our sister team at Oxford University to try and see if existing data can be analyzed to flesh out some of the questions we have in multiple countries. So if you don't have $2.5 million to run a cohort of 3,000 adolescents, maybe we can capitalize on an existing data set. Some of you may have supported these surveys in the countries you work in. They're called, these two specifically, they're called the Violence Against Children and Youth surveys, which are led by CDC and colleagues at PEPFAR and country teams, and the Multiple Indicator Cluster survey led by UNICEF, which I know many countries support and work on. Your countries may actually have VAX data sets, so you can borrow the code and run this analysis in your countries if you're interested. We have focused on the countries on the maps. In the Lesotho case, we try to find what we're calling development accelerators. What are things that will impact multiple outcomes concurrently? So statistically speaking, this means taking into account correlation between variables in such a way that if you find significance, it's actually independent of the others. And what we found is that there were 3 things. You'll see a theme here. I hope you won't find it super surprising by now. But good parenting or caregiving, so a young person reporting that they were looked after in a way that felt good. Positive gender norms and access to economic strengthening were the 3. These were not things we gave people, by the way. These were things they said they had. And we just built a comparison in the data set using a matching statistical technique. The combination of those 3 was associated with improvements in those outcomes. We see a similar pattern in Namibia, but here we see that what makes the greatest difference is food security, so not being hungry. And this brings up a question for colleagues in country. If you can't give people money, which is a big issue, the deserving poor, giving people money, they may use it for things you don't think they should use it for. Then one can do other things with money, and it often comes back to things like hunger, supporting parents to not be stressed out, and the harder work of shifting gender norms. In Ethiopia, we saw something really wonderful in an existing program, and this is quite relevant to those of you and us who are working not just through the healthcare system, but also through cadres like community healthcare workers. There's been a lot of task shifting in the continent, expecting people who are not medically trained or technically trained to bear a huge burden of care for our large communities in need. Well, in Ethiopia, the program was super structured, and it actually had impressive outcomes, not just at what they intended to help at the start, which was wash and sanitation, but you'll see here that families of adolescent girls who were visited by these community healthcare workers and graduated also had improved improvements in how well they did in school. It was not the intended effect of the HEP, the Health Extension Program. But it did what it was intended to do, delay pregnancy, child marriage, early marriage, but it also improved school outcomes. I'm almost done. I'll tell you a bit about where we're going. But just because I thought some of you may work in Malawi and Zimbabwe, what we see there using the multiple indicator cluster surveys is that those who access social protection in both countries, and the social protection system in Malawi and Zimbabwe look very different. In Zimbabwe, it's a lot more agriculture-based. So this isn't saying you must give people money or must do social protection the same way. But those families that access the existing schemes in both countries, adolescent girls and young women saw a reduction in adolescent pregnancy, early marriage, marriage before 18, and improvement in school progression for both adolescent girls and boys. So where are we heading to now? We can't afford to just focus on a single issue. I came up through the HIV track. That's how I was trained, HIV prevention, HIV response. But one can't deal with HIV without thinking about sexual and reproductive health more broadly, without going into violence and mental health, and grieving and orphanhood and climate change and not having access to good services because your country is in a political upheaval. So this is where we are now. And what we're trying to do next is to try and think, how do we take this data to different spaces? The World Bank is interested in using some of these findings for their COVID recovery fund, so we're very lucky to work there. We have a team led by Professor Lucy Kluver at the University of Oxford that is working with NGOs and communities affected by the Ukraine conflict to try and see how do we take some of the parenting tips that the team has developed over time to support families in times of crisis. And at the end of the Pakistan floods, the team also responded by trying to work with local NGOs and provide them some evidence-based materials that they could use. But we still don't know what is the best combination of things to do. So I'll finish in, I think, a slide. But what we're trying to do is go a bit further. We have lots of big data. There's a lot of issues around data privacy we'll all have to deal with. But now we have both the machine learning capabilities, humans who can hopefully prevent AI from taking over. I'm sure there's lots of you interested in that topic. I did not use ChatGPT to develop this presentation. But the goal is to try and combine GIS information with district-level data and individual responses from surveys to give us more data that can be used for that precision programming. There are lots of political issues with this. It's probably nearly impossible to go to the Eastern Cape and say one district should do these 3 programs and this other district should do just 2 of them. But to give people the data where they can base some of their decisions on is our goal. And to try and cost it. It's very easy to actually say, do these 3 beautiful programs, but if you don't know how much they're going to cost and the impact relative to the cost that you're putting in, that's actually doesn't help decision-making that I'm sure many of you are facing. And we have a lot of costing data, we just don't analyze it. So all of us implementing, doing research, sending grants to people, we don't actually bother to ask, what did it cost you to reach 1 adolescent girl and young woman? It's one of my advocacy points. I'm not going to do that. It's not my expertise. Just wanted to say thank you to all of you for listening. And these are some of the funders and collaborators that we have. And this is the children of our team at UCT during Family Day last week. So I often look at this picture to remind myself why we're doing this. Thanks, everyone. Thanks for being here.